and welcome to today's webinar, Without Social Determinant Data, It's All Guesswork. My name is Laurel Rodriguez, and I am the Director of Marketing at Ecovia Solutions. Our presenters today are Jim Kalani, Principal Program Manager for Ecovia Solutions, and Ed Daniels, Principal Consultant for First Response Management, LLC. Today, Jim and Ed will discuss the shift in modern healthcare away from coordinated reaction to emergencies toward a whole-person care paradigm, how communities employ a comprehensive care plan to mobilize and coordinate resources and providers to address the social determinants of health, how to use predictive analytics to discover patterns in patients' health. Before joining Ecovia Solutions, Jim was the Chief Technology Officer for Community Health Partnership, a member-based coalition that managed care for over 180,000 members in Region 7 of Colorado's Accountable Health Collaborative. At Community Health Partnership, Jim led an initiative to develop a community-based strategy that optimized care delivery for high-risk populations, such as homeless, long-term services and supports, elderly, blind, and disabled, and those who overutilize the emergency departments. Jim has 25 years of experience in health information technology leadership with a Juris Doctorate in law, a master's in business administration, and a bachelor's of science in biochemistry. Ed Daniels is the principal consultant for First Response Management, LLC. His firm provides health IT consulting and software development services to healthcare organizations specializing in organizational planning, interoperability, healthcare analytics, and population health management. Ed worked closely with Jim at Community Health Partnership and played a key role in developing the community-based strategy for optimizing care delivery. Prior to consulting, Ed held several executive management roles, including CEO of RMD Networks, Inc., Vice President of Operations and Corporate Integration for Virtuity, a privately held telecommunications company, and President and Chief Operating Officer of SalesRep Online, Inc. Ed also held several executive positions in other healthcare and data-related companies and ventures. Ed earned a master's in industrial engineering from the State University of New York at Buffalo and a bachelor's in psychology from Southern Illinois University at Carbondale. Ed is also a retired fire chief. Just a quick note before we turn the webinar over to Jim and Ed. Jim will have some time at the end of his presentation, as well as Ed, to address your questions. You can also follow the webinar conversation on Twitter or submit questions using the hashtag you see on the screen. Jim, Ed, I will go ahead and turn the time over to you.
Hey, great. Thanks, Laurel. And thanks, everybody, for joining today. Real quick, just to do a quick agenda for today's meeting. We don't have a ton of time here, so we'd like to walk through kind of the state-of-the-art of the health journey, so to speak, and healthcare services provision, and then kind of recap very quickly the previous webinar that I had done by myself, which was developing a comprehensive care plan, and then move on to the core of this, which is predictive and prescriptive analytics, the data infrastructure that's necessary to be able to do those things, specifically incorporating social determinants of health information from varied sources, and eventually, if we have time, getting into how to create a learning organization and bring all these pieces together. We'll have, I believe we're going to save about 10 minutes if we can for questions and answers, so please submit any questions that you might have through the webinar to Laurel, and she will get those over to us or ask us those questions. And so I'm going to turn it over to my partner, Ed. I can briefly tell you folks, Ed and I have been colleagues for quite some time. We met in this Medicaid project here in Colorado where we were attempting to do something pretty innovative, which was bring in acute and non-acute facility clinical information into one data warehouse, be able to organize that data, parse that data out and associate it with historic claims data, and then begin to start applying some machine learning and analytics to that data, and then push that out into a front-end tool, which ClientTrack actually used to be a client of ours, and I ended up coming over and working with Ecovia, and ClientTrack is the tool, by the way. And so that's kind of the final piece, the actuating piece, the in-field tool that is used to collect this data and notify care coordinators, care providers, et cetera. So with that, I'll turn it over to Ed, and you can talk a little bit about the state of the art.
Thank you, Jim. This is Ed Daniels, and thank you all for joining us today. We're excited to be here with you. It's such an exciting time to be in the healthcare world because things have just progressed so dramatically, and that doesn't mean to say that everybody has all the healthcare that they need, but the technology has moved forward from public health, which really just clean water and sewer systems and just the basics that have brought us into the current era. And with the immunizations and those types of services, we've really progressed a long way just by providing the basics. But now we're in a very interesting current time where we've been able to digitize many, if not most, health records, and this provides us with the data to be able to do the types of analyses and communications that we were never able to do before. And it positions us to move into a very exciting future, as Jim described, where we can do big data analytics, machine learning, and really understand the populations that we're responsible for and understand the type of actions that we can take in order to improve the health of the people that we serve. So, Jim, I'll hand it over to you, and you can talk about human services and transition.
Sure. And this is a slide that I had on the previous webinar I did, but really the transition here is going from treatment of health problems, so which in general, and I've been in trouble for saying this before at certain seminars I've given, but really, I mean, when people go to see a physician, usually it's to treat some type of condition that's happened, and moving into the paradigm of actually preventing them, and preventing them not only with, you know, the non-IT or technology methods, but actually employing technology to be able to do that. And we're at a place right now where, you know, the technology's there, and so it's just catching up with that. And healthcare in general as a vertical is fairly good in horizontal innovation. They have the best equipment and things to do for treatment and diagnosis, fairly poor in horizontal integration of technology. I think we all probably know that. So that's where we're going. The prevention piece, which we'll talk about later, is really the predictive versus prescriptive type analytics, how we incorporate social determinants of health into that. In other words, treating health problems, it's one thing to be able to predict what's going to happen. It's another thing to be able to prevent it, and they're very different methodologies in that you can have all the information in the world that knows what's going to happen and then not be able to do anything about it because you either lack the tools necessary or the resources to do so. So in the health and human services transition, this is pretty much the core of the issue we're trying to deal with. Is the healthcare landscape is increasingly getting more robust in its technology and less robust in bending the needle of the cost curve. Provider costs continue to go up. A lot of this, an example of that is duplicative testing, duplicative radiology or labs, and only because the varied members of the what I call health team or health neighborhood, just to have the inability there's an inability to talk with each other, to share data across enterprises, you know, be it, you know, radiation results or whatever. So that's really the problem. How do we integrate these two? How do we lower the provider costs by having a consistent continuum of information throughout the entire health community? We'll go to a quick recap of the previous webinar. We talked about a few things. We talked about whole person care paradigm. We talked about how to strategically plan for that, how to build a true comprehensive care plan, and then the required infrastructure that needs to lay beneath that to make and actuate all of that work. When I talk about whole person care, many of you are probably familiar with that concept. I currently am a program manager for a pretty massive whole person care program for Medi-Cal in California, and it really goes well outside of the typical clinical look at a patient's health. It goes to things like including jail and reentry type things, employment, housing, food, accessibility, transportation, and being able to bring all of those things in, which really are the social determinant pieces. We have the clinical pieces, we have the claim pieces. We just don't, you know, have the information that we need on why a diabetic may not be able to get their insulin because they don't have a ride type thing. So it's really a holistic approach to that. how we strategically plan, I'll get to that in a second, and then building that comprehensive care plan where all of the different people that all the touch points for this patient, be it a therapist, a nutritionist, a physician, a chiropractor, a care coordinator, are all operating at some level on some basis of information stack for that patient. The whole person paradigm is pretty well exemplified here. Physical care or primary care has been handled from EHR systems, as we know. You get the clinical information that your physician has. If you belong to a health network, then it's anyone that you've seen within that network. It's pretty good. Claims data usually can be accumulated and processed into that. But again, the clinical information is only one piece of it. Now, the behavioral health part, as we all know, can be a little more complicated if you're trying to aggregate that data, just due to federal regulations, privacy regulations that are specific to behavioral health issues. So that can be a challenge. And then the piece that we're going to talk more about today is really the social determinants, the community-based organizations, which frankly is the biggest gap in this healthcare continuum, is gathering that information about this person that has this problem, why is it not getting better? It's not getting better because of these factors that you will not find inside a clinical record, you will not find inside a claims record. You will find through interactions in the field with a care coordinator, interacting with possibly your Department of Health and Human Services, or gathering that information in field and plugging all of that into an ecosystem where then you can use machine learning, use some data science, and to try to predict what's going to happen and then get in front of that through some type of prescriptive analytic methodology. Okay, so the last webinar we talked about how do you start? What are the items that you need to consider when you're looking at building a care coordination system and strategically planning your comprehensive health record? So why, right? Why are you trying to do this? It's very important at the beginning to understand what you're really trying to accomplish and what data you have to start with. Who controls the data you're trying to get? I mean, if you are an ACO type model, you will be privy to claims data. Depending on the environment you're in, you may be privy to clinical data for a certain patient population. This can be a very disruptive process on gathering data, as we all know. Acquiring data from different sources, many folks are very protective about this and don't like to share data. How are you going to impact what you're trying to do? How do you plan to gather all this data, and then how are you going to impact folks with the data that you're getting? Is it through a community leader? Is there some type of consortium like, for example, Community Health Partnerships, where I worked, which was a collaborative of various leaders in the healthcare industry here out in Colorado Springs? Then what are you going to do with the information? How do you disperse this information once you have it throughout the community, which really goes to a front-end care coordination type tool or GUI, graphic user interface, where people are able to delve into the information that has been gathered and assembled for this patient? When do you want to do it? What is your timing? How do you have to do something immediately? A lot of folks have grant funding issues where they have to a very short timeline, or is it an iterative process when you have time to continue to build on your infrastructure? And then where are you placing the data? Extremely important. I work very closely with Microsoft's Azure platform. It's in the government space. It's a FedRAMP approved, very, very secure platform for the data to land, and that's what Ecovia and ClientTrack land all of our information onto. So it's a very secure environment. But how are you going to manage the data governance of all of the things that you can collect? It's one challenge to go out and get the data. An equal challenge is to make sure that you protect that data when it's under your care. Okay? So I guess I'd leave it with coming up with a strategic plan that would really address these things on why, who, what, how, when, and where. We'll go on to, we talked about a comprehensive health record, which is, there's been a lot of talk with Epic and some of the main EHR and EMR vendors about developing this comprehensive health record, and I have many friends that work in that industry, and I think it's wonderful what they're doing, but to be clear, when they call things comprehensive health records, it's really a comprehensive clinical report card of what's happened. So it's a comprehensive record of what happened back there. So just important to make that distinction. I mean, the solution is really taking that medical record along with claims record, along with event notification capabilities, and then applying the prescriptive type analytics we're going to be discussing and coupling that with social determinant. Ed, do you want to?
Yeah. So this is Ed again, and just want to mention about the medical record systems as opposed to a more comprehensive care plan. In our consulting work with first response management, we work with a lot of different organizations, and we find a lot of communities that are just coming together and understanding the broad data requirements for the entire health neighborhood. And so we work with physician practices, for example, that I've begun to realize that they need to include social determinants type of data in their work with each individual patient, but yet their medical record system doesn't really embrace the ability to be able to handle that additional data. And so one of the types of projects that we do is help these organizations figure out whether they can sort of stretch the capabilities of their medical record system to encompass social determinant data, or whether they need to bring in another type of specialized system for care coordination purposes. And if they end up with both types of systems, a medical record system and a care coordination system, then what do they do in terms of linking those systems together to make that data available to both the physicians, PAs, nurse practitioners, social workers, et cetera, on the more clinical side, and the care coordinators, care navigators on the more social and community side of things. So that's something that takes some pretty intensive analysis and planning, and it ultimately results in an economic investment that the organization needs to make. But one of the elements of that can kind of bridge the gap between these different types of systems is the comprehensive care plan. And again, I recognize that the last webinar was on this topic, but just to drill down a little bit further, because this is an important and emerging area, the comprehensive care plan is something that is more a concept that ultimately gets embodied in computer software. But the concept is to have a plan that encompasses both the physical health needs, the behavioral health needs, and the social environmental needs that each individual has in our overall managed population, and to put that in a document, whether computerized or not, that encompasses the different actions that are most necessary. Now, it might be a medical or surgical type procedure that a patient requires and has to be prepared for, but it might equally well be nutrition or socialization or transportation that that patient requires in order to maintain their health. All these things are embodied in the comprehensive care plan, and all work towards the goal of resolving the gaps in care. What is it that any individual person or cohort within our population needs in order to resolve these gaps in care? Now, there are computer standards for comprehensive care plans, but a lot of organizations followed their own path in terms of putting a comprehensive care plan together. But the key is it's a communication tool. It's something that physicians and care coordinators and health navigators and the patient themselves and their own personal caregivers can use to keep everybody working as a team and focused towards resolving those gaps in care and moving towards maximal health. So if we look at our communities, there's all kinds of elements that we have to work with and that a patient and a patient's caregivers have to contend with. Urgent care centers that seem to be popping up all over the place in our more urban areas. Patient-centered medical homes that inherently take a larger, broader view of the patient. Youth and family services, comprehensive care clinics, the hospital itself for acute care episodes, outpatient, substance use treatment, and diagnostic centers, ambulatory surgery centers, et cetera. We have a huge variety of these different organizations that all come to bear on specific care requirements for people in our patient populations, but getting these organizations to all work together, to not start over from scratch Jim mentioned earlier, duplicate X-rays, duplicate lab work. If we can enhance the communication among these organizations, then we can reduce some of that duplication and we can reduce the overall cost of care, which of course is a critical element to all of our jobs in terms of helping to do what we can to control increasing healthcare costs. So how do we tie these neighborhoods and these groups and all these different provider agencies together? Well, I want to talk for just a minute about what Jim and I put together on a project that we worked on previously, which helped to put together the IT infrastructure to be able to pull these organizations together. And I think that this slide is representative of the type of systems that all of you need to consider as we move forward, because this type of a data management system provides a core for a lot of the technology, but also programmatic evolution that we all are working towards. So just looking at this diagram, if you look at it from right to left, if you look on the right-hand side, you can look at some of the sources of data that Jim and I identified in our state and our community that had the type of data that we needed to have in order to help manage this population. And in our case, it was a Medicaid program, so the state had a lot of Medicaid data. In our case, the state is responsible for processing the Medicaid claims, so all of the physical health data resided at the state level. But in our case, there were separate behavioral health organizations that had their data for managing and working with the patients that had behavioral health issues and a behavioral health history, and so we had to separately gather that data and match it against the physical health data. And then also in our situation, we were fortunate enough to have a functioning health information exchange that was able to gather near real-time data from healthcare activity in the state. So this health information exchange was connected to hospitals and was working aggressively to go out and connect to physician practices. It was connected to clinical labs and a number of other places where patients go and get their care. So we were able to tap into that health information exchange to gather that data. So ultimately, by use of a data integration engine, we were able to put all this data together and store it in a data warehouse where we were able to normalize this data and be able to know that a particular patient at Daniels, myself, saw my primary care physician. You know, the primary care physician identified a particular problem that needed surgical remedy. I was admitted to a hospital, and I was then discharged from that hospital and followed up with physical therapy, and perhaps I needed some type of behavioral health counseling in order to adjust to the changes that I experienced due to that physical problem that I had. All that data was available in our data warehouse and was able to be tapped, if you look at the far left-hand side of the equation, by the care management system that we had put in place to work with our care managers and make available to them this type of information. And then also, if you look at the left-hand side of that column, data analytics, we could use our data scientists and analysts to look at this database and be able to understand the characteristics of our health population, understand the type of activities that made a difference versus the type of activities that we thought were going to make a difference but didn't make a difference. And we'll talk more about that as we move forward here. But
hey, before you go, because I know you're going to get into social determinants. So one thing I wanted to mention, I did this on purpose. If you notice the diagram I left up, I did not put the backward arrow coming in from care coordinators and the other providers on the left-hand side of this into clients. I did that so I could speak to this real quick. So this is the part where gathering social determinants of health can be a little bit easier if you have a front-end tool that you're using that's out in the field, that's a economically viable tool that can go to places like soup kitchens and things like that, and food banks, et cetera, where they can actually just put in information. So there is a bi-directional feed that comes back into that front-end tool and then is populated back into this data warehouse through an integration engine. We happen to utilize All Your Data, which is a company out here and has an integration engine called BizExplorer, but I bring that up because if you look at the centerpiece of this before I change it, the data warehousing piece, the data integration engine is key to being able to take in disparate sources of data, populate them through, and it worked pretty well.
Thanks, Jim. So the topic of this whole webinar is social determinants of health, and I'm sure that many of you that are on this call are already experts in working every day with the social determinants that have such an important bearing on all of us really, but especially certain of the subpopulations that we work with, the Medicaid populations, the older people, the disabled, the people that are sometimes out of the mainstream of our society, but are influenced and their health is influenced so strongly by these different determinants. You know, in preparing for this talk today, I did a little bit of research. I was just reviewing the social determinants literature that is now so easily accessible on the web and looking at all of the papers and studies that have been done on social determinants. There are papers that summarize all the literature that's out there that identifying the key social determinants. There's a lot of international work on social determinants in a lot of different societies, and there are even controlled studies that are done where certain populations are randomized and a subset of a particular cohort is treated to certain types of support in their social determinants areas such as nutrition, transportation, substance use counseling, etc., whereas the other segment of that population is not, and then the effects of those types of interventions are tested. So there's a huge amount of literature out there, and it's all very important, and we could use up the rest of our time talking about that, but the key, which we'll talk about a little bit later in this webinar, is how can you, yourself and your organization, use this information and see how it bears on your particular population that you're responsible for, and how can your organization learn from what's going on with your population in order to improve care of those individuals. So what we have up here on this slide is a list of different social type of determinants and physical types of environmental determinants, but I just want to relate one organization that I'm currently consulting for has done some of this work within their own organization, and so they have gathered their different sources of data. In this case, they have many disparate systems. They haven't yet put them all into one data warehouse, but that's one of the things that we're working on with that organization. But still using some analytic tools, they were able to extract data from their different systems, pull it into one analytic database, and then analyze the data to look at the impact that certain social determinant interventions had. And what they found was things like child care for people that have children and don't have child care, food insecurity, people that are worried about their next meal, home heating, which we think about and we take for granted, but people that can't pay for or don't have adequate heating in their home, housing instability, they don't know where they're going to be staying the next night, inadequate education, meaning typically less than a high school level of education, and unemployment, were things that this organization studied not just through the literature, but within their own population, and determined that interventions that they took in each one of these areas actually had a statistically significant impact on the overall cost of care for this population. And they haven't gotten to the quality measures yet. They mostly focused on cost of care just because of, you know, they needed to make this case with their financing agencies. But anyway, it's just an example, though, of what your organization can do to focus on what's the situation with your particular population. So, Jim, with that, I'll hand it over to you, and we could talk about some of the more technological requirements here.
Sure, yeah. So to get into a little bit more of the meat of this, so Ed and I have some differing and some consistent views on this. We actually had a discussion before this webinar about the term prescriptive analytics. So the technology stack, Ed just had gone through that. And the next slide, I'll take a different cut at looking at actuating data into information and to other things. I will say predictive analytics is pretty much what's going to happen. Prescriptive, that's where we have our impasse on what prescriptive, if it's even analytics. And social determinant of health data acquisition, which Ed's talked a little bit about, but having a front-end field tool is the way to go there. So I'll go to a pyramid here, which many of you are probably familiar with this concept. And so if you look at the pyramid here, data, now that's the thing everyone wants to get. They want to get their data. And so they have their own data, and then they want to go get data from other sources for a business reason that they have. And there are challenges, you know, I like to think of this as an equation. On every side of the equals, there are positives and negatives. I can tell you in LA County, the positive is that access to that data is easy to get. If it's a county facility, that could be mental health data, jail data, it could be employment data, housing data, food bank data, whatever it is. So the data acquisition is fairly easy. However, sharing of that data, once you amass that volume of data, that body of data, then brings into security and data governance concerns. Now that you have all this, you have to decide who gets to see what. And so, again, it's a zero-sum game. So how does the data get turned into information, right? That's the next piece. You have data on John Smith. You have his claims history. Great. You have John Smith, his ER visits, or you saw the ER 2 times as clinical data from, say, a hospital. You throw it into the bucket. Is it the same John Smith? So, I don't know, is it J. Smith? There's clinical terminology factors that have to be considered. So turning that data, that raw data, into information, something that's actually usable. Is it the same person? Does it even matter? That's the second piece of the stack on this pyramid, is kind of turning that and sanitizing that data and organizing it into a form where eventually here's John Smith's historical data, here's kind of real-time and historical clinical data, and then you start applying knowledge to it. So John Smith is a guy that's 50 years old, and he's been to the ER for certain lower abdominal pains recently, et cetera. But then applying some type of analytics, or at least knowledge of the fact that he's a 50-year-old man, he probably hasn't been in for a colonoscopy, going back and then recycling through the claims data and his clinical history and saying he has not had one, so we need to probably try and actuate that, right? We need to figure out what we need to do and get in front of this thing. So all of that is kind of past what's happened, why did it happen, okay, we know all that. It does nothing to do with solving the problem of bending the needle both on costs and on healthcare. So then we move into the next part, right, which is the future. So the wisdom part of this is what's going to be the best thing to do, and I'll give 2 examples that are very different from each other. One would be, if we know that we have captured social determinant data on this person that's seen the ER, it's a diabetic, and they continue to go back there, and we know the reason, we know because our in-field people have used some care coordination type tool and have gathered that data that this person is either homeless or at risk of being homeless, definitely economically disadvantaged, and the care coordinator came back and said, I spoke with Susie, and she doesn't even have a refrigerator to keep her insulin cold. That's one example of something that can be impacted, right? So then the care coordinator can utilize the community resources or what have you, and fix that problem. The alternative on the other end of the spectrum is wisdom, and this is a personal experience where you have your frequent flyers that call, 911, and then out here in Colorado Springs we call it the CARES program. So the fire department goes out and meets this person, and you know that the reason this person is calling is because they maybe have a mental health problem, and they just enjoyed the conversation with the paramedic that shows up every time. right? So there's a differentiation, and that's where the wisdom becomes in, and what are the things we can impact? Maybe we don't send a complete ambulance or a fire truck on the call to this person, when really what they may need is a social worker, you know, or a psychologist, psychiatrist or something. So that's when you start applying wisdom to how you expend your healthcare resources and efforts to best impact people. And the third example is there are many folks that just aren't going to do anything you tell them they're going to do. There's no way. You can tell them they're going to die of a heart attack, a care coordinator or a care navigator or a physician can talk to them until they're blue in the face, and that is not a pun. And they just will not do it, right? They just won't do it. So you have to totem pole and prioritize how your efforts are going to be applied. That's where analytics and planning can go into this. The future piece of this decisions is really the prescriptive part, right? So in other words, you know what's going to happen. If we call this person, they're not going to do anything. That would be my lead into what is predictive analytics. The prescriptive piece of it, though, is we know this person's not going to do anything. Is there anything we can do to get in front of this? Or we know, in other words, Susie is going to be in trouble because her insulin can't be kept cold. That is a predictive analytic method. We know this is going to happen. She will be in the ER. That's predictive analytics in a nutshell. I don't know if it's prescriptive analytics again, but it is prescriptive to say if we go and we get her some way to keep her insulin, you know, cold, then she won't be there. So I'll turn it over to you.
Yeah, I think that's a great example. So just changing gears just a little bit, data science. For those of you on this call, I'm sure that people are at a lot of different points in their career, but just looking at job opportunities in the U.S. today, a data scientist and a data analyst are among the greatest opportunities and highest paying jobs that are available. So this is a hot area, and I would encourage anybody that's either at the beginning of their career or looking at making a career change, if you're inclined at all towards this area, that's a great opportunity. So many things are happening and so many tools are now available that it's worth looking at. So again, talking about data analytics, this is something that we all have to do every day in our programs. We have to report, we saw 20 patients today. There were 50 people that visited our nutrition center. There were 20 people that spent overnight in our respite center, but those are some very basic analytics or reporting. Now we can dive down to the next level. If we collect more detailed data, we know the individual identity of those people. Now we can start slicing and dicing that a little bit more. You know, of the people that utilize the respite center, 10% of them were diabetic, 25% of them were on Medicaid, and you know, another subset of them were referred there from their primary care physician. Those types of data are interesting just in understanding our population. But then moving into predictive analytics, that's where we begin to start understanding the characteristics that ultimately lead to a particular situation. And there's a lot of science that goes into how predictive analytics works, but essentially you look at a time series of data. In other words, say the last 3 years of data on these patients that are using our respite center, and we look at what happened over the last 2 years, their age, the referral source, their medical conditions, and then we use that 2 years of data to predict what is going to happen in the third year, and then we test that against the data set to see if that's valid. And then, so that's called a data experiment. We just experiment with the data we have in order to try to predict things, and then we move that into the real world and really test to see if our predictive mechanism, our formula, it might be a mathematical formula, it might be something as sophisticated as an artificial intelligence neural network, but we test to see if what we thought was true really ends up being true in the real world. And then moving that forward into prescriptive analytics. So, again, Jim and I were tossing this around before we got on the webinar, and I was saying, well, for me, predictive analytics is it going to rain today? And prescriptive analytics is, if it rains today and I go inside, am I going to keep dry? And so that's testing to see if your intervention actually had the effect that you thought it was going to, and ultimately figuring out which intervention makes the most sense. And to add a financial side to it, how much did that intervention cost versus how much did that intervention save in terms of reduced healthcare costs in the population. So those tools are now available as long as you have the data to be able to examine them. And then knowing all this is one thing, studying it in a book or being a data scientist, but how do you make it real in an organization? And that's where learning as an organization and double loop learning comes in. And so now I'll talk about that for just a minute. So the basics of organizational learning are what kind of changes should I make in order to make an improvement in my health population. So again, sticking with the respite center, if I have 20 beds available for my population, and I know that a certain subset of people are going to have a surgical procedure and they're going to be discharged and they have issues with homelessness, and so I find that if I have 20 beds available in my respite center and I can discharge patients to that respite center that have problems having a place to live, then I am going to reduce my readmission rate and help those people achieve improved outcomes. Then I collect data on that fact, on the history of those people that were able to use the respite center versus the people where there were not enough beds available, and so they ended up having to go back out on the street. I find out the differences there, and I find that based on the data, if I increase the number of beds available, I would actually reduce the readmission rate and be able to save additional health care costs. So I go back and adjust the number of beds in reserve an additional 10 beds, so now I have 30 beds in my respite center. And so as a learning organization, I've used the data to find out that I can change this intervention in order to improve outcomes and reduce costs, and I can take that information and that learning back to my funding organization, my CEO, whoever I needed to get the dollars to reserve those extra beds, and be able to demonstrate quantitatively that I can save money. But that's a basic learning organization, and we should all, I'm sure we're all a learning organization to some extent, but we can all get better at that. But now the next level of this is called double loop learning, which means you're not just looking at, okay, instead of 20 beds of respite health, let's have 30 beds. Maybe the real problem is homelessness in the first place, and that really what our organization should be doing is looking at finding a permanent place for these people to live so that we don't have to worry about the respite center in the first place. So that's double loop learning, and there again we can use these quantitative mechanisms to demonstrate the financial impact of doing this. That might just be a hypothesis. We might test the data and find out, no, it didn't really save as much as it cost. We got to find a lower cost mechanism of doing it, or we might find out that it pays itself back double, and we should double down on that particular program. So this double loop learning is something that we all should strive for in our organization, and I should say that the IT computer systems that are behind this type of learning have some essential qualities to them, and that is flexibility, and not only the capture of data that we've been talking about through this entire exercise, but also the flexibility to be able to gather new data that you didn't anticipate. None of us are smart enough to know all the data that we need to have. A lot of organizations we work with are technology deprived. They don't even have computer systems, but through the flexible types of systems that are configurable. We can add new data fields. We can quantify what is regular text-type data into numeric data, and we can change these sort of things on the fly. Then we're able to adapt and continue to learn and be able to put quantitative information behind our organizational decisions. Jim, I'll turn it back over to you.
Yeah, no, I was just going to say maybe before it's really our last slide, and we'll do Q&A. We got 5 minutes, so let's just let's do a real-world example, okay? And I'm going to leave this slide up here. Hopefully, everyone you'll get copies of this deck. But if you can remember, I'm not going to mess with going back on the slide deck right now. I've already failed at managing this today. So if you can imagine, if you look at this double loop learning thing, where would a care coordination, what a front-end tool, a community-based tool that like Client Track, like we offer, impact? Where does it land in this? Okay, so here's John. John goes to the ER, right? And he's admitted for some condition. Okay, so if the ER is connected, or if the care coordinator is notified through some event notification, which we did in our program too. So the second John hits the ER, if you remember when Ed was talking about how the HIE, the Health Information Exchange System, had a notification that would notify a care coordinator. There was a rule set up. So care coordinator John says, hey, Joe's in the hospital, I need to do something. Now, he can pull up that clinical information. What's going to happen? Well, he's going to go to respite when he's released. Great. Does he have transportation? Well, the only way to know that person has transportation really is if you have some of that social determinant of information, or they're going to be, put outside the ER, right? So let's get transportation. Let's organize. It's more care navigation than care coordination, really. It's just navigation. Okay. Now at respite. Now, if the respite person has a tool, a community tool like this, where they say, oh, I see what happened. They were at the ER, and there's a care coordinator associated with this person. Okay, and there's their name and number, and so okay, got it. So going to be a few days, I'm going to make my note. Okay, they make their notes on what's going to happen. Care coordinator says, hey, this person's getting released. Wait a minute, they have nowhere to go. Right, they're homeless or something like that. So now you're using this in-field tool to gather those social determinants that, I mean, the idea of going to DHS or some other type of census thing and trying to figure out if this person has shelter, has food, those types of things is, I would love to be the consultant on that project. It'd probably be very lucrative, but I don't know how you do it. But to have that tool, now you've got this continuum here where people are using this front-end piece that's been built on that infrastructure that we showed you, so that when they're released, maybe they are taken to a different facility, maybe it's a skilled nursing facility, right? Maybe it's to a halfway type house, depending if they have drug dependencies or any SUDS issues. Maybe they're taken to, your community mental health center or something like that. But that's the true continuum of care in this health journey, whereas that one day makes the difference. If they get out of the ER and they're not picked up, and they're not taken to a respite, it's over, and the cycle starts again. If they leave respite and there's nowhere to go, the cycle starts again. If they go somewhere from respite and there's no follow-up, the cycle starts again. And hopefully somewhere are wonderful physicians, and I mean that, in their workflow, there should be a connection back where they can reconnect with their patients, and then they would have a true thing where they don't have to search through 17 PDFs to find out what happened, and then populate that back in. It's a great theory to be able to populate that back into EHRs, but it's coming to a clinic near you soon, hopefully. So, Laurel, I mean, we've got, I guess, about 10 minutes left, I think, 9 minutes left. So we'll stop there and take any questions if you've received any.
Yeah, well, thank you, Ed and Jim, for the presentation. So we are going to open up the webinar now for some questions and answers. So the first question that we received is, how does a government health department client differ from a hospital client? Who's invested in these solutions, and how is the space changing?
Wow, that is a great question. Let me just make sure I understand again. So how does say that again one time, Laurel?
How does a government health department client differ from a hospital client? Who's investing in these solutions, and how is the space changing?
Okay, so I think there's a couple things, and so why don't we do this for the Q&A? I'll throw out my stuff, and then I can chime in, and then vice versa. So a couple things come to mind. The first is, I will tell you, having the luxury of having a commercial health payer, right, I am reminded when I was 50, my mailbox was filled with notifications to go get that thing that guys do when they're 50. Right? There was no chance, in fact, incentives, even I think, you know, maybe some Starbucks cards or something from Blue Cross to go and get my colonoscopy. So in the Medicaid space, from a government type client, there is nobody that's doing that. At least I can tell you, speak from experience here in Colorado. I mean, that is the obligation of the, they call them RICOs or RAIs now, but the accountable organizations that are in charge of managing the administration of care coordination and navigation. So unless somebody is doing this, you know, commercial health plans are wonderful at this. Believe me, it ties to their bottom line, and it's good practice. So they know the types of things based on HEDIS measures, which women need to, you know, have breast exams and things, just various HEDIS type measures. They have notifications, they have their analytics built in, fine. On the government or, you know, the non-commercial payer side, not so much. I don't know, do you want to speak a little bit more to that?
Well, you know, I think the question isn't so much whether it's a governmental agency or a hospital. The question is, are you managing an overall population towards improved outcomes and reduced costs, or are you simply providing certain treatments and care for specific individuals? Whether it's a hospital that's responsible for managing a population or a government agency that's responsible for managing a population, I think all the things that we've talked about apply to what needs to be done and needs to be encompassed. And it depends what types of clinics and programs and providers that are available to that agency, again, whether it's a hospital or a government agency. But the general principles of having a learning organization, of gathering all the data that you want to influence, of analyzing that data, identifying the most effective interventions across both physical medicine, behavioral health, and social determinants, those things all apply to either case, in my opinion.
I'll just ice that cake real quick with one other thing because it's timely, and that is we dealt with this. The interaction between on and off, right? So the churn between payer sources is massive. In other words, gathering until, I'm not going to be on a soapbox because we all know this, until the patient owns their own data and can manage it, this is going to be a problem. But when somebody comes in and out of Medicaid into a commercial payer scenario, there's a huge gap, and the gap there is that the information exchange is just difficult, and I don't mean that from a HIE standpoint. I mean the exchanging of what happened to this person. There's very strict rules based on Medicaid, Medicare data being shared outside of that environment. So when someone is no longer eligible or on Medicaid, that data is locked down, and it's difficult to share that to a provider, a commercial provider or payer. Right, and so again, I just wanted to make that distinction. I think there is a lot of churn and there's a lot of gaps in care based as that churn happens. So,
yeah. So the next question is related to that. So, what is your consent process in order to maintain HIPAA compliance?
Another great question. I can speak to the client, the front end tool that we're talking about today, or maybe we could speak more globally. Why don't you speak globally if you want about just the whole consent MPI type thing, how we do with that, and then I'll talk.
Well, yeah, I think consent is a challenge all up and down the line of our organizations, whether it's you know, the federal HIPAA and other types of requirements, whether it's states, and of course states have different laws regarding consent and the sharing of health information, and down to our individual organizations themselves and the types of internal rules and priorities and regulations that we have for the use of data. So consent is an issue all up and down the line, and traditionally consent is handled by a form that you receive at your doctor's office or your other provider or caregiver's office where you sign on the dotted line and say that my insurance company can have access to all of my information, and it can also be shared with these other organizations or individuals. We're moving towards a system where that can be done using computerized tools where the individual can control the consent down to a very granular level, talking about, for example, limiting, providing general access to their physical health data, but limiting access to any kind of substance use data or behavioral health data, or permitting that kind of use, and to what organizations and agencies that use are going to have access to that data. So I think that technology is in a primitive state, but I'm guessing that we're going to have very rapid evolution where people will be able to go to their smartphone, their computer system, to a kiosk, and be able to control that consent down to the individual level. But for the moment, it's challenging.
Yeah, no, I'd agree. And I'll take it down to a real life example. So dealing with this right now in the program that I'm running, and that is not only consent of what information, but then if you're dealing with cross-organizational consent, you may consent for the person that, say, is a benefits enrollment person. I'm going to consent for this social worker that's assigned to me to have access to all this information. But I only want this person who's going to try to help me get a job in a housing type, an employment type situation to have, I'm consenting to that. So that's one thing. I mean, it all comes down, I think, to data governance and role-based access and privileges. The rules, the technology, I think, is there. It's really organizational decisions on how those rules are applied. I mean, the technology can say, if this, then this. So I think that's there. I would say I think the next generation, I hope, would be tied to a master patient index where the patient controls it just like they control their own, Snapchat, I guess, or Facebook. I don't have those things, but where they can control everything that's associated with their master patient index. So that number identifies the patient, and consent somehow is embedded or tied to that can be managed by that patient. And not only their consent of who can see the information, but also family members and care team providers on their own. They could say, I don't like Dr. Fred anymore, so I'm going to get a different doctor and turn off consent. It's close. I think we're reaching the point of singularity here on this, I think, within the next few years. But anyways, the way we manage it is exactly that way. If someone comes into a client track system and they are a new patient, say, in a housing for health type environment or an HMIS environment, they can come in and say, we consent to give this information to so-and-so. If it's going to be cross-organizational, then there are security protocols that we build into that say these boxes have to be checked or you don't get to break the glass to see that if you're in a different organization. I don't know if that answers the question, but.
Okay, yeah, so thank you, Jim. So we actually have a few more questions. I know we're up against time, Jim and Ed, are you good with answering a couple more questions? If anyone needs to sign up, we will be sending out the webinar recording and slides.
Laurel, we're here. I apologize if there's background noise. Let me know. The fabulous Thunderbirds are doing their tricks over the Air Force Academy, so let me know if I need to mute. But we're here for as long as you want.
Okay, no, that's great. So, okay, so the next question, so it says, the collection of social determinants data at the front end is valuable, but usually clients come to the front door with a set mind and will not provide all the factors we need. How can this gap be filled?
I think so from my standpoint, there's two things. It depends on what door, right? Like what door are they going into? If they're going into a situation, again, not to keep bringing it back to, but it's my life, what I'm doing right now. If they're going into a door that has to do with an eligibility or a benefits type organization, it's fairly simple. You provide the information or you don't get the benefit, right? I will say that we have dealt with some of the nuances about that. In other words, some folks don't want to talk about their level of education and things, and so there's a balancing act on how important is this really in providing this person the services they need. But I think it comes down to, is there give and take? In other words, if it's a funded program that you're working with that requires this information, if the people are unwilling to give it, they're denied. I mean, that's what it is, and there's reasons for that. So if it's not that strict a protocol, I think it comes down to, again, some types of policies and procedures about what is the information you really need to gather. I'd love to know more if the person's interactive with you right now on a chat thing. I'd love to know a little bit more deeper into the question, but do you want to?
Well, I just want to say, I mean, I think there's a lot of different dimensions to this, but one is if you can collect some information, it's better than no information, and a lot of times we want to collect this information in order to find out if that variable is really important. If we can just get enough information to do a quick analysis and determine what's really important, then we can move forward. It may make sense to make the investment to be able to gather that data more quantitatively and get the data from, for example, the Department of Justice if somebody doesn't want to talk about their incarceration history, or a nutrition center if they don't want to talk about the fact that they had to go to the soup kitchen to get their next meal. You know, ultimately you might be able to get these data through automated means, but in the first step may just be the interview with the counselor or the intake person.
Hey, Laurel, I had one other thing to add to that.
Okay.
So in Colorado, you know, you have to opt out, right? So it made our life a lot easier when we were building this infrastructure, unless you, outside of behavioral health, let me make that clarification. So when you go to a hospital, you have to say you don't want your records shared. So it makes things a lot easier. But I would say, I think there's another shift coming too, and that is that person on the intake piece of it, no longer, you know, it typically, historically has been an administrative person that checks the box, right? That is the first touch point of that person coming in for help, seeking benefits, whatever. And I think we will see that the ability of that intake person, even if they typically had been more of an administrative role, to work through that conversation with that patient can make a big difference. In other words, these are the things and these are the reasons we need to know this, right? As opposed to, if you don't tell me your level of education, you're not approved. It's like, well, these are the reasons and blah, blah, blah. So I think there's going to be more of a discussion at that initial intake thing, which probably will help manage that.
Okay, perfect. So the next question is, what level of data can hospitals share with social service providers?
I guess that depends. So I got to make some assumptions, okay? Let's assume that the patient has consented to sharing all of the data that's in their hospital record, okay? It's a complex question. It's a great question, by the way, complex. So let's just stay with clinical. So if someone, say in Colorado, comes in, they go to the ER, they're inpatient, and they've consented to that. If there's a relationship and obviously a business associate or data sharing agreement between any of the social services type folks, DHS, whoever, and the hospital facility or health consortium, then non-issue. I mean, there's not an issue. They've consented, and it flows downstream through the legal mechanism, which is the data sharing agreement, or BAA. Okay? Where it gets tricky, and vice versa, by the way, of course, right? So as long as that agreement is in place, that consent travels, right downstream or upstream. Where it gets tricky is there are different consent modules, and in the ER specifically, it's very different. If you go to a community mental health center or a substance abuse provider or some type of addiction therapist or psychiatrist or psychologist, there are very different consent. You have to consent into those things. However, in a hospital setting, there are things, I'll give an example, medications, that can be indicators of things that would violate 42 CFR Part 2. Anyone that were to see this medication that knows what they're doing would know that it was in for treatment of this. And so that's where it gets tricky, because you have somebody in an urgent, I don't mean urgent care, I mean an urgent situation. An ER doc's doing his thing, they're making their notes, they put it in their EMR system, consent's been laid down. The consent really wasn't around a mental health or a substance abuse type thing. I mean, putting down lithium or thorazine, you know, big deal, right? That's what it is, that's where we're going. So that's tricky. I have not seen any cases that have come out where anyone's gotten hurt legally by that. Yeah, but I don't know, do you have any comments on that?
No, I think
I don't know if that even answered the question.
Right,
yeah.
No, that was great. If anyone has any follow-up questions on that, let us know. So one last question. Have you considered assigning a universal ID that crossed over multiple systems?
Yes.
That, you know, that is, of course, been an issue in the United States since the beginning of computerized systems, and there's still a lot of resistance to the idea of a unified, universal ID, a lot of debates about whether it's a good idea or not. Clearly, it would make life a lot easier for system developers like us if we had a universal ID, but the good news is that the new so-called master person index, enterprise master person index technology is really, really good. And so with the use of MPI, master person index technology, we're able to perform almost as well, or some vendors would say even better, than the assignment of an individual identification number. So it adds cost and complexity to system design, but I think that we're at the point of being able to, for the large part, overcome the hurdle of not having that identification number, which is pretty much, it's just a challenge at all levels of government here in the United States.
Yeah, and I'll add one other thing to that, Laurel, and that is, so what's happening is, once again, here we go, the typical, you know, EMR vendor thing where people build their silos. So health systems will say, we're going to assign our own MPI, right? For everyone that's under all of our patients that we pay for, we're going to assign them a number, right? Providers may or may not do that. Well, they do it. Here's a patient number. And so if you think about it, this is one of the ways we were able to overcome some of the clinical terminology and data normalization things in the pyramid and the infrastructure that Ed talked about. When you can imagine you have a hospital, hospital A that sends in a hemoglobin result that is capital A1, capital C, and that's the field in the CCD, right? Huh?
Small c.
Yeah, small c. Right, that's the field in the continuity of care document. And so that gets ingested into your thing. Then you have another hospital, same patient, right? Or maybe it's their primary care provider, and say they're on NextGen and it's small a1, small c, right? And then so you have to have that rules engine in there to say, oh, this equals this, we got it, right? That clinical terminology that manages that. You put it through some algorithms, maybe a 15-point test that says, okay, this is that person, this is a hemoglobin result, this is what it is. That same thing is going to be the next paradigm of people saying, here's this patient, and here's this patient, same patient, different patient numbers from different places, and we're going to be back in that business again. That's why the integration tool that we used on this was so good, that it actually had rules associated with matching those things. And so an NPI at, you know, say, Molina Health System of this for this patient, and an NPI at this primary care provider is the same person. You know, if it's not, put it into purgatory, deal with it later, but it is, then you populate that data and normalize it. And I think that's where we're going eventually until, I wish, frankly, to end this question is, I don't know why we can't tie them to Social Security numbers, but that's a whole different topic altogether.
Great. Well, thank you so much, Jim and Ed, and thank you for everyone that stayed around with us for a few minutes longer. And thank you so much, and we hope you can join us for future webinars. Have a great day.
Great. Thank you, Laurel. Bye-bye.
Thank you.